last Wednesday. So our topic is kidney surgery. So this is just a follow-up of the lecture of Dr. Rabanan. So first is the flank approach. So the patient, for a flank incision, the patient is placed in a lateral decubitus position. The table should be flexed between the iliac crest and costal margin with a kidney bar raised. The structures of the retroperitoneum are in this position are better exposed. However, care needs to be taken to avoid injury of the contralateral kidney. So this position may not be that ideal for patients with pre-existing cardiopulmonary deficits. So here's a picture of a flank approach. Here's a picture of a flank approach. So the subcostal approach provides, we will start with the subcostal approach in the flank position. This provides excellent exposure to the proximal ureter and the renal parenchyma. It is well suited for approaches to the lower pole and UPJ and the proximal ureter. However, access to the renal hyoid in the flank approach is poor, making this position somehow limited for large renal masses. After induction of anesthesia and insertion of the ET tube and a Foley catheter, the patient is then placed in the decubitus position. The head is supported to avoid excess flexion at the cervical spine. A kidney bar can be employed if necessary. The tip of the 12 rib should be positioned over the kidney bar. So we wait for the 12 rib and then put it on the kidney rest or kidney bar. The patient back is supported by a rolled blanket or a surgical beanbag. To preserve stability and prevent forward roll, the dependent leg is flexed at the hip and knee, so the lower part. And a pillow is placed between. So also don't forget to put an axillary pad to avoid compression injury at axillary area. So after sterile preparation and draping, the incision begins at the proxinalis muscle, just inferior to the 12th rib. The incision is made a finger breadth below and parallel to the 11th rib, to the 12th rib, and is carried onto the anterior abdominal wall. In an attempt to avoid the subcostal nerve, the incision can be curved gently downward at the mid-axillary line. If needed, the incision may be extended and then border of the rectus abdominis. So the posterior serratus cell in which the lower ribs are inserted, this should be encountered when the wound is transected. In the anterior aspect of the wound, the anterior oblique muscle is then divided. This maneuver exposes the fused lumbodorsal fascia, which gives rise to the internal oblique and the transversus abdominis muscle. By using two fingers inserted into an opening, creating the lumbodorsal fascia at the tip of the 12th rib, the peritoneum is swept medially as the transversus abdominis is split digitally. The subcostal nerve should be identified between the internal oblique and transversus abdominis. To maximize the exposure in the posterior aspect of the incision, one may incise the posterior angle of the lumbodorsal fascia, exposing the sacrospinalis and quadratus lumborum. So you can see in this picture, once you open the transversus abdominis, a peritoneal shadow should be seen and should be pushed medially. So the level of the incision, the location of the lesion and the planned procedure. Positioning similar to, we'll proceed now to the supracostal flank approach. So the skin incision for the supracostal, kanina subcostal, now supracostal, the incision should be made at the superior aspect of the 11th or 12th rib, beginning at the lateral border of the sacrospinalis muscle and continuing to the lateral border of the ipsilateral rectus abdominis muscle. The incision is carried through the subcutaneous tissue, the latissimus dorsi and the serratus muscles are transected in the posterior aspect, revealing the intercostal muscle. So you proceed with the same procedure as mentioned earlier, with with moving the peritoneum medially. So next is the dorsal lumbotomy approach. For this approach, it is typically reserved for pediatric patients and for thin adults requiring bilateral nephrectomy. The advantage of this approach is low morbidity because no muscle in this position is transected. So I use this picture. I discussed this last Friday. So the other incisions are for the adrenals, but for dorsal lumbotomy, it is below the 12th rib. So the dorsal approach is an anatomical approach to the kidney with incision of the fascial planes rather than the muscle. So vertical is made from the inferior border of the 12th rib up to the iliac crest with the lateral border of the sacrospinalis muscle. The subcutaneous tissues and the latissimus. The upper separated from the posterior layer where it overlies the sacrospinalis muscle. The posterior layer of the dorsolumbar fascia is a strong fascial coating. It is incised, then allows sacrospinalis to be retracted as shown as in this picture. So the ilioinguinal nerve at this approach should also be identified and spared. And to the space is incising the transversalis fascia and division of the perinephric fascia to expose the kidney. So next is the thoracoabdominal approach. So the thoracoabdominal approach is for the management of renal masses, suprarenal or upper pole masses, renal tumors with venous extent, tumors in adjacent. The position in a same manner as the same as the flank approaches, with a rolled blanket and beanbag supporting the flank. The legs are also positioned in a similar manner, but the but the levelation is determined by the nature of the tumor, the tumor including the size and relationship of the surrounding vessels. The access is gained through the 8, 9, 10, and 11 intercostal space. So the incision begins at the lateral aspect of the supraspinalis muscle over the 10th and 11th rib as shown in this picture. So for this approach, the underlying peritoneum is opened and the peritoneal cavity and the chest are entered, staying close to the superior border of the rib. The incurred exposes the pleura and the diaphragm. The pleura is open sharply, taking care to avoid the lung. And then the costovertebral ligaments are also divided. Eventually, you will see the diaphragm, which is open from the thoracic surface. The liver and the spleen is gently retracted upwards, as shown in this picture, the on the right. and then, uh, and then, uh, the hepatic mobility can be obtained by divide the coronary ligament and the right triangular ligament of the liver. So for left-sided tumors, the colon and the tail of the pancreas are mobilized. So for the right side, you may also proceed with the Cocker's maneuver. Next approach is the anterior midline approach. This is carried out in a supine position, and the midline skin incision is carried out between the base. So in the cautery and the linea size to expose the underlying pre-peritoneum. The peritoneum is then grasped with two forceps and during the bowels of the anterior. For approach involves a vertical incision in the posterior peritoneum below the uh, to the left renal hyrum is through. In this approach, the gastrocorigentum is then divided and entered. Actually, I actually we paths of with right and right side. So other approach are anterior subcostal and the incision. So for anterior subcostal approach, the patient is placed in also in supine position. Some surgeons roll blanket under the spine to facilitate exposure with hyperlordosis. However, uh, the excessive hyperlordosis can lead to unwanted tension on the great vessels, minimizing its blood flow. And then next is the chevron incision, which is composed of the bilateral composed of bilateral anterior subcostal incision. This is actually ideal for renovascular surgery and radical nephrectomy with thrombectomy. So now we're finished with the types of incision. We'll proceed with nephrectomy. So first is simple nephrectomy. So please don't call on this. Uh, I I actually know it's not a simple surgery, but it's actually called simple nephrectomy so it is actually the removal of the kidney within the gyrotous fascia. It is used to manage non-malignant diseases of the kidney. The indications are usually non-functioning or poorly functioning kidney, result of obstruction, infection, thrombosis, cirrhosis, ureter flux, polycystic kidneys, or dysplastia. So a simple nephrectomy of functional kidney may be employed to relieve the intractable symptoms or associated problems such as bleeding, pain, hypertension, or persistent infection. So for simple nephrectomy, the posterior layer of the renal fascia is bluntly dissected from the muscles of the posterior abdominal wall. The anterior layers of the renal fascia is dissected from the colonic mesentery and peritoneum, leaving a fascial compartment in which the kidney, adrenal gland, and perirenal fat lie. Then the renal fascia is then incised, and the perirenal fat is separated from the kidney using a combination of um, blunt and electrocautery. So care should be done to avoid bleeding and difficulty in approaching the several surgical. So the surgeon must be also aware of a vessel typically found near the poles and in the areas of resistant to blunt dissection, in which cases the posterior dissection is difficult because of adherence of the kidney to the psoas muscle. Include the psoas fascia in dissection may be helpful if necessary. In cases of a large hydronephrotic kidney, in which exposure is difficult, what you can do is you can puncture and aspirate for the renal contents, and then this may decompress or aid in of the. So next is the adrenal gland. It may be dissected from the upper pole directly on the renal capsule, and then the superior attachment of the kidney to the spleen, pancreas, and liver may follow. Ideally, it should be done. A caudal retraction should be done to safely to put tension in the kidney downwards. So next is the lower pole of the kidney. It is mobilized and the ureter is isolated. Gonadal vein adjacent to the ureter. When it is identified, care should be taken to mobilize this to avoid traction. Once the between surgical clips and septi, division of provides access to kidney and better exposure of renal structures. So from a cranial approach, usually identified after the division of the ureter, and then a combination of the vein is actually a picture of subscapsular nephrectomy. So now we're nephrectomy will do partial nephrectomy for benign diseases. A partial nephrectomy, in addition to its common utilization for the treatment of small-sized renal cancer, it can sometimes be useful for benign diseases. In some cases, it is indicated in patients with hydronephrosis with parenchymal atrophy, atopic pyelonephritis in a duplicated kidney. Also for infection and significant segmental trauma with irreversible damage. And also for removal of benign tumors such as angiolipoma, oncocytoma. So this approach, the partial nephrectomy, can be used by excising the site. And then eventually you can repeat through rhinorrhaphy. So later partial nephrectomy for malignant diseases also. So next is a radical nephrectomy. So radical nephrectomy actually refers to a complete removal of the kidney outside the Gerota's fascia together with the ipsilateral adrenal gland and complete regional lymphadenectomy from the crus of the diaphragm to the aortic bifurcation. This was the description in full description. However, today the adrenal gland is spared if possible because when the adrenal gland is not involved in the tumor, you may preserve this. And also, extensive lymphadenectomy is only done in cases when it is strongly felt that it may contribute or improve patient survival without adding complications to the patient's recovery. So technically, it's still controversial. It is actually not required because the overall incidence of lymph node disease is only about 5%. So regional lymphadenectomy should be patients who may be have a reasonable chance in benefiting from the added surgery. So the indications are enlarged lymph nodes, on imaging, cytoreductive surgery for metastatic disease, and tumor size of greater than 10 cm, or nuclear grade of grade 3 or greater, and also for sarcomatoid histology. The presence of tumor necrosis on imaging, intrarenal tumor expansion, and tumor thrombus and tumoral invasions of the adjacent organs is also an indication. So we'll proceed with the procedure. So the posterior parietal peritoneum on the white line of Todd is insides from the pelvic region of the iliac artery to the right quadrant of the region of the hepatic flexure. The anterior is developed by dissecting the plane between the anterior renal fascia and the mesentery of the ascending colon. So in this, it is important to resect the renal fascia in its entirety for the best chance of survival and cure and avoid intra-abdominal tumor spillage. So after mobilizing for the hepatic flexure at the and sharp dissection, the second part of the duodenum is then mobilized. So this is the uh, first. After mobilization of the duodenum, usually the IVC should be identified at the posterior part if you're doing an abdominal approach. The dissection is carried out, and then the vein identified. So you place a vessel loop and gentle traction to the renal vein. The vein is should be palpated for any thrombus. If the identification of the renal artery is difficult, you should proceed with mobilization of the lower pole of the kidney to identify the ureter and the gonadal vein. So if technically feasible also, you should also spare the gonadal vein. However, because most of the time, the renal not identified and it's just ligated. So with ligation of the ureter, the kidney is lifted posterior to an anterior position to aid in identification of the renal artery posterior to the kidney. So in this picture, that's why I placed this. So after your ligation, you should be conscious with other vessels such as the lumbar vessels because they're usually identified at the posterior part and oftenly missed. So for the left part, the left ladyectomy, after the incision of the white line of Toll, this time from the splenic flexure to the common iliac artery. So from the splenic flexure down to the common iliac artery, the descending colon should be reflected. The left renal vein is identified using the anterior surface. The left renal artery then usually located and posterior to the left renal vein after mobilization of the lower pole of the kidney and the left ureter. So the next part was this already discussed from the previous slide. Like at times that the artery and renal vein cannot be separated individually because of significant hilar lymphadenectomy, then a whole pedicle clamp technique may be utilized. Although there's a risk for AV fistula uh, associated with emulsion when the vein and artery are sutured together. So the pedicle should be pinched and the clamp is placed at the lowermost aspect of the pedicle to ensure the adequate length of ligation of the pedicle, that the clamp extends far beyond the structures within the pedicle to engage the suture. So usually for this, you can use a Satinsky clamp. And in this picture, a second clamp is placed above the adjacent to the first under direct vision, and a third clamp is placed near the pedicle, near the renal parenchyma. So it's numbered 1, 2, 3. So one clip for the specimen. The pedicle is then divided between the second and third clamps, leaving vascular stump protruding. A O-silk suture is looped below the lower clamp to tie off. It's prudent to tie twice, and also suture ligation to minimize the risk of bleeding. So for the wound closure, for in some cases, it is prudent to test for pleural injury. The retroperitoneum should be filled with saline. Then you ask your anesthesiologist to inflate the lungs with high inspiratory volumes. Bubbling of the saline irrigation in the retroperitoneum with deep inspiration would suggest pneumothorax. In cases of pleural injury, this can be closed with a running absorbable sutures before closure of the pleura. The tip of a French 14 catheter is placed in the pleural cavity, and the end of the catheter is then placed in a saline-filled bowl. And then the anesthesiologist again provides an inspiratory breath to evacuate in the pleural cavity through the red rubber catheter. And then once the air is evacuated from the pleural cavity, as evidenced by the bubble in the saline bowl, you may then you may pull out your catheter. And then chest radiograph is essentially needed to assess for any significant pneumothorax post-operatively. So and then the subcutaneous tissue is approximated using a 3O absorbable suture, and the skin should be approximated with stapler or a subcuticular 4O monocryl sutures. So we'll go back for partial nephrectomy and disease. I already introduced how it's done in the discussion of the benign diseases. So it is important to talk about the renal hypothermia. So the renal hypothermia should be 20 degrees Celsius. It takes at least 15 minutes to achieve the kidney while it's packed with an ice slush. This prevents the post-operative renal failure. You may give mannitol, 12.5 grams per kilogram, and a furosemide, 20 milligrams. This should be infused about 15 minutes before clamping of the artery. Although it is somehow limited, both drugs is quite safe and as long as the patient is well hydrated to avoid renal injury. So when partial nephrectomy is performed, the perirenal fat and renal fat should be preserved. The entire renal surface should be visualized and all visible tumors should be resected. And you may, in this picture, this is actually an intraoperative ultrasound. This can be used for subcortical tumors that should be resected. And again, hyperthermia is actually advisable to minimize injury to the renal parenchyma. So let's start with small tumors. The renal cortex surrounding tumors is marked circumferential with electrocautery, and the plane outside the tumor or subcapsule within the normal parenchyma is identified and bluntly dissected with small closed Metzenbaum scissors. Then for enucleation, renal occlusion is usually not necessary. However, if there's excessive bleeding that hampers proper visualization of the resection margin, then a manual compression of the kidney or clamping of the renal pedicle may help. Vessels of the kidney are encountered, they are divided sharply with scissors, and the tumors then excised. The margins are examined for gross evidence of a positive surgical margin, and then it is excised and may be sent for frozen section analysis. And then the small bleeding should be closed with a suture ligation using a 4O absorbable suture. In closure, this is actually a new net pledget. It is placed along the border of the excised renal parenchyma, and in the bottom of the incision. The defect is then closed with two absorbable using an horizontal mattress as seen in letter B. The suture is placed along the 2 meter internal parenchyma to and tearing. Allows of tension in the capsule, and then the perirenal fat and fascia are replaced around the closed suction drain. Parenchymal space is placed to monitor bleeding and urine leaks. So the closed suction drain is removed after 2 to 5 days when the outcome. Also, Folic used to monitor the urine out. So in some cases where collecting cysts, one may put ureters if it requires. So next is the wedge resection for large cortical tumors. For large cortical tumors, again, required to do hyperthermia. Based on preference, when partial nephrectomy is being performed, tumor sizes or the renal may be clamped. So after the so also you may also clamp this together renal artery to provide hemostasis. Then a plastic bag is placed around the kidney filled with ice and the procedure earlier. Cutting, give combination this size within the tumor is section. So for closure, say here, unit suture and clamp the clamp at the renal artery, and then you inspect for bleeding. The segment for large tumor poles. So again, you give your mannitol and furosemide after, then the artery after 15 minutes using a bulldog clamp. it may the clamp. You may also place this if you see the segmental artery. So provided that is supplying the pole in which your tumor is located. So also the avascular line can be demarcated by carmine directly into the clamp artery. So in this picture, you may inject it here. If you and then usually ideally located line where you can do your resection. So when the apical segmental artery is ligated, the renal pedicle is clamped with end block using a Satinsky clamp, and then is an ice flush before you cut out your tumor, and then release the usual controlled bleeder. So again, this should be a unit pledget described in the previous slide. Because the defect is large, we usually need a larger needle for polar nephrectomies and nephrectomies. See, she considered lies may be mobile and it may cause occlusion. This may be done in the psoas muscle and contratus lumborum. So next, this types of thrombo. We'll discuss this. Level 1 be the PM of pain. Level 3 to 3 bring me for right-sided tumor. Renal base in the suprarenal IVC and the please bear with me. Left renal intra are identified as sure to help ligation to 6-inch.
Pangit internet.
Akala ko right-sided tumor. So again, the IVC should be clamped, and then the IVC infrarenally should be clamped, and then eventually, once you palpated all of the thrombos, a Satinsky clamp is placed posterior to the defect, and the Purlin suture on a vascular needle should be done using using a continuous suture. However, before you close this, you should allow up to 5 to 10 ml of blood to escape from the caval defect to be sure to flush out all the thrombus and fragments. So next is the level 2, the left-sided tumor. So a vascular control is obtained by sequentially in this order. So first, the left renal artery is ligated, and then the infrarenal is IVC is clamped here, and then the contralateral right renal vein is clamped, and then the suprarenal IVC is clamped. So, and lastly, the accessory hepatic veins are ligated to the caudal lobe. So this maneuver is to gain 2 to 3 cm extra infrahepatic IVC exposure. So the renal ostium is then circumferentially excised, and then the excision is extended superiorly into the anterior surface of the IVC using pot scissors. So then a Penrose dissector a Penfield dissector is used to carefully extract the tumor thrombus from the IVC. The caval defect is then closed using a 4-0 Purlin sutures. And then again, you should allow flushing of 5 to 10 ml of blood just to seep off the caval opening to clear the debris and air. So next is the level 3 and
Rome,
4.
How do you release it after the repair? Yung mga
So,
clamp mo, sinong unahin mo, sinong susunod, etc.
so it should be released in this order. So first, it should be released opposite from how it's clamped. So first, the accessory hepatic veins, and then the suprarenal IVC, and then the contralateral right renal vein, and then the infrarenal IVC, and then the last, and then yun na pala yung last, sir, because the left renal vein is ligated. So in that particular order. So next, for level 3 and 4, the priority is to do transesophageal ultrasound to measure the cranial extent of the thrombus and to monitor the thrombus for fracture and embolization. When I say fracture, it means the throwing off of the thrombus superiorly. So for this, the liver should be mobilized by ligating and dividing the ligamentum teres, the remnants of the obliterated left umbilical vein that is located above the lower free border of the falciform ligament. So the falciform ligament is then divided with electrocautery up to the upper border of the liver, where it branches into the coronary ligament on the right and the left triangular ligament, as shown in this picture. So the ligament is then divided anteriorly, and the hepatic mobilization is completed by dividing the posterior aspect of the left triangular ligament toward the IVC. The right lobe of the liver can now be safely and gently rotated toward the midline so that the IVC can be evaluated on the posterior surface of the liver. For tumors of the left kidney, it may be necessary to divide the diaphragmatic attachment of the spleen so it can be rotated toward the midline with the pancreas without being it traumatized. A window is created in the lesser omentum and the porta hepatis. This contains the portal vein, common hepatic artery, and the common bile duct. It is encircled with the tourniquet, clamping the porta hepatis it's actually the Pringle maneuver, which is necessary to prevent massive blood loss if the IVC is clamped above the major hepatic veins. Then clamping the IVC above and below the hepatic veins while performing the Pringle maneuver. This is actually called the total hepatic vascular occlusion. So lastly, this is a different approach. So for level 3 and 4, the thrombi that cannot be removed intra-abdominally, these are managed by combining an intra-abdominal and intrathoracic chevron laparotomy with sternotomy, anterior midline laparotomy with sternotomy incisions. So it is preferred to do this one, the anterior midline laparotomy with sternotomy. And a cardiothoracic surgeon needs to participate in the planning. So this is actually almost identical to the intra-abdominal approach as described earlier. Once the abdominal plane is complete, the abdominal phase is completed, the thoracic surgeon is called, and then he opens up the pericardium will be open, and then the heart is exposed. Open mobilization of the liver and the IVCs is easier once the sternotomy is completed, and the blood supply is bypassed once the techniques from the abdominal approach I mentioned is done. So also a right atriotomy. So the right atrium is usually performed. The right atrium is opened to help remove the suprahepatic thrombus, and the IVC and atrium are then eventually closed. The patient is taken off bypass and thoracotomy tubes, and then closed suction abdominal drains is placed. the hepatic ligaments are tackled back into place to prevent torsion of the liver, and the regional lymphadenectomy is performed. So that's it for nephrectomy, for kidney surgery, specifically simple and radical and partial. So for laparoscopy, I actually discussed this last week. It's same as the laparoscopy for adrenalectomy. The dissection will be almost the same as the abdominal and flank incisions. So do you have any questions for that long lecture? So if none, this lecture is actually sponsored by our friends from J&J, the distributors of Zytiga. So, Ma'am Lani, are you able to talk?